So asthma is a common problem. 20% of children in India at some stage in their life will have asthma. Recurrent or chronic cough, wheezing, shortness of breath, tightness in the chest, or poor exercise capacity. So any combination of these symptoms will make us suspect that the child has asthma.
Inhalers, they will be addictive. The children can never be out of it.
There is a myth that children get addicted to these kind of treatments, the inhalers especially, but that is a myth. We use these medications in a very low doses delivered directly to the lung. So these do not cause any addiction. About 50 to 60% of our children actually outgrow asthma. So there is a good chance that Indian children with asthma, if you're treated properly, the asthma can get better, or even the child can outgrow the asthma.
Hi everyone, I'm Dr. Shomosri, fellow in Pediatric Pulmonology in Rainbow Children's Hospital, Hyderabad. And today I have with me my mentor and guide, Dr. Naveen Saradhi, who is a consultant pediatric pulmonologist in Rainbow Hospital, Hyderabad. Hi sir, how are you doing?
I'm fine today, Sumashri. How are you?
All good, sir.
Yeah.
So, the first question that comes to the mind of a parent is that who is a pediatric pulmonologist?
I think this is a very good question. Pediatric pulmonologist is a specialist who's a pediatrician who's trained in the area of pediatric pulmonology and also usually in the areas of sleep and allergy. This is a specialist who look after children with lung problems, mainly. Yeah.
Okay, sir. So, who should come to a pediatric pulmonologist?
So previously there was a shortage of pediatric pulmonologists in India, but increasingly there is an availability of pediatric pulmonologists in the major cities of in India and especially in Hyderabad. So any child or any family in which there is a child who has chronic or recurrent lung problems should come and see a pediatric pulmonologist. Yeah.
Okay. And what are the common lung problems that we see in our clinics, sir?
So in our clinics, what we see, the commonest problem children come with is chronic cough. Okay, a cough which doesn't go for periods of time, and I think that is your most common reason for coming to the clinic. Second, we have children with asthma, which is a big and a common diagnosis. Children come with various forms of allergies, which leads into asthma and breathing difficulties. So that is the kind of the commonest list of patients. Along with that, we see a lot of the very uncommon and rare lung problems which need to be identified early and treated early. I'm sure you're going to ask me more questions about that.
Yeah. So talking about asthma, when do you suspect that a child is having this?
So asthma is a common problem. There is a big taboo about talking about asthma.
Absolutely.
So, and I think that has to change. We currently estimate that 20% of children in India at some stage in their life will have asthma. So it is a common problem. How you recognize asthma is if a child who comes with recurrent or chronic cough, wheezing, shortness of breath, tightness in the chest, or poor exercise capacity. So any combination of these symptoms will make us suspect that the child has asthma.
Okay, and how do we go forward in diagnosing this condition, sir?
So asthma is largely a clinical diagnosis. What we depend on is the history that the parents give us. That largely helps with the diagnosis. Along with that, what we do is we've got certain specialized tests, such as spirometry. We can also do some blood tests looking at allergies and other things. So this helps us diagnose asthma. So one of the commonest tests that we can do in older children is what is called a spirometry, which is also called a lung function test. This helps pick up asthma. But the most important thing in younger children, especially the one who are younger than 5 years, we do what is called a trial of treatment. That, in fact, is a clinching thing. And I think if a child responds to a trial of treatment, it's likely to be asthma.
So what are the treatment options that we offer to children with asthma?
So once we made a diagnosis of asthma, I think the best treatment modality we have is use of inhalers. inhaler therapy is a worldwide, it's a standard treatment for asthma. We use what is called a metered dose inhaler. So once we've made a diagnosis of asthma, we have pretty much a very standard format of treatment. These we follow based on the international guidelines called the GINA guidelines. So the mainstay of therapy of treatment of asthma is what is called a inhaler. This is what is called a metered dose inhaler. This is what is called a spacer. These are the devices which we use to deliver drug directly to the lungs. So this is a mainstay of treatment. Along with this, we also use other medications sparingly, such as nebulizations, and also some oral medications to reduce the inflammation in the lungs.
Okay, sir, but we have a few parents, few relatives who are always behind us asking that inhalers, they will be addictive, the children can never be out of it. So how far are we going along with this inhaler, sir?
So there is a myth that children get addicted to these kind of treatments, the inhalers especially, but that is a myth. Okay, so we use these medications in a very low doses delivered directly to the lung. So these do not cause any addiction. So we use it on a need-based basis. Normally, when a child comes to us for the first time, we have a trial of treatment for about 3 to 6 months. After that, we stop, we reassess, and then we go again. So it all depends on how long a child needs the medication. And I can very clearly tell you that there is no addiction potential for any of these medications, and please use it without any doubt.
Okay, and sir, is asthma a lifelong disease? Can it be cured?
So, this is my experience coming from the West and the East, actually. So, what I've seen in the UK and Australia and other countries is that asthma in children tends to be a bit longer or even for a lifetime. But my experience in India shows that asthma can get better with time. In fact, in the last 4 years, what I've seen is about 50 to 60% of our children actually outgrow asthma. So there is a good chance that Indian children with asthma, if you're treated properly, the asthma can get better, or even the child can outgrow the asthma.
You know, many children, they get up in the morning, they have bouts of sneezing and nasal blockage. So what can be the causes of this?
So it is a very common problem that we see in children. Parents report that the child has gone to bed quite comfortably, wakes up in the morning with a cough or sneezing. This is typically a marker of an allergic or a reactive airway. What happens in the morning is the temperature drops and there's an environmental change. Children do react to that and they can start coughing or sneezing. The second thing which can happen is that these children can have specific allergies, especially when you're in the bed and when you're using pillows and mattress covers and those kind of things. You are exposed to what is called a house dust mite, which is a very common allergen in Indian children. So when a child spends 8 or 10 hours in the bed, so this allergy to this house dust mite can lead to this early morning coughing and sneezing. So this needs to be evaluated.
Coming to this sleep problem, sir, what are the common sleep issues that children face in India?
Sleep is a big problem in India. I think adults don't sleep properly, children don't sleep properly, and there is very less attention to given to sleep hygiene. And in fact, this is a big passion of mine that we need to improve sleep quality in children and in fact indirectly the adults also. So now to give you a rough estimate, a teenager should be sleeping about 8 hours a day. A younger child should be sleeping about maybe 7 to 10 hours a day depending on the age. An infant or a toddler will sleep for much longer. But this will happen only if there is something called a sleep hygiene. Parents should be aware that a child needs to sleep, a certain amount of sleep, and a certain quantity and quality of sleep. This can be achieved only with awareness and proper training. So one of the biggest problems that I see in children in my clinical practice is that children are not sleeping enough. That's one. Second, you might be sleeping for 8 hours, but the quality of sleep. If you're restless at night, if you're coughing or snoring at night, then your sleep quality is affected. That is the second big problem that we see. Along with that, we see problems with sleep hygiene. In fact, many of our families, everybody reaches home by 6 or 7 or 8 o'clock. Dinner is had at about 10 o'clock or 9 o'clock in some families, and children go to bed only after 11 or 12 along with their parents after watching a lot of TV or something like that. So this is completely unacceptable. What we should try and aim is slightly early dinners and have fixed time for dinners. Second is no screens at least 2 hours before sleep, and trying to sleep at least by 9 or 10 o'clock, if not 7 or 8 o'clock as in the West. So if we do that, there's a set routine. The parents tend to sleep along with the children, and I think everybody gets some quality sleep time. So this is a big issue. Along with that, I think we see a lot of other complex sleep problems. So my message to parents is, if your child is not sleeping properly for long hours, or if you think the quality of sleep is a problem, then please see a pediatric pulmonologist who's trained in sleep medicine.
A frequent problem that parents come up with is the child is sleeping. He's having 8 hours of sleep at night, but he's snoring a lot, and there are frequent awakenings during the night, and even during the day he's feeling sleepy, and he's not able to concentrate at his school. Complaints are coming from the teacher. So what is the issue with these children?
So children who are snoring at night, it's a very common problem. You snore at night if you have a couple of problems. One, your nose is blocked, or you have a tissue which grows at the back of your throat called adenoids or tonsils. So it's one, a blocked nose, or you've got increased size of adenoids and tonsils. These happen when a child has either allergies or infections. This need to be kept in mind. Most of us snore a little bit, but that is fine. It's called primary snoring. But if it becomes significant, if it's loud snoring, if the child is restless sleeper, or if the snoring is almost every day causing sleep disturbance, then it is a problem that needs to be addressed.
Okay, so what are the treatment options for children with adenoid enlargement?
Okay, so we see a lot of children who come to the clinic with adenoid enlargement. So one of the problems which is reported by parents is that this child is either has a blocked nose constantly, a runny nose, or there is a lot of snoring. Now, what we need to do in this situation is we need to assess why the child is snoring. In fact, sometimes you can also have a cough with these symptoms. So you can have either a nasal allergy or adenoidal enlargement. And in fact, in some children with both these problems, you can also have lung involvement or mild asthma. So it's all about assessing what level, what problem is there. Because if you look at, from my perspective, the airway starts right at the nose and ends up in the lungs. So what we now know, it's called a unified airway disease. You cannot have a problem in the nose without having a problem in the lungs. So there'll be some problem. So that needs to be assessed. So now coming back to your question about snoring, if a child has significant snoring and we think it's because of a blocked nose or adenoids, we start some simple medications. First is a nasal spray and an anti-allergic medication. So that's the first line of treatment. Second, we need to identify the exact cause of why it's happening. We can either do some tests like x-rays and CT scans of the neck and face, or we can also do some allergy testing, because allergy is an important part of the story. So based on this, we treat the current issue while looking at the root cause.
Okay. Sir, what is a sleep study? What does it do?
Yeah, it's a very good question. A sleep study is a comprehensive study which is usually done in hospitals in a proper sleep center to assess the duration and quality of sleep. It is a gold standard in assessing how well a person is sleeping, either a child or adult.
And what is the procedure that we follow for a sleep study in the hospital? How much time does it require? And what is the general instruction that we give during this study?
So sleep study is, there are three types of sleep studies: level 1, level 2 and level 3. So most commonly nowadays what we are seeing is level 2, level 3 studies which can be done at home. These are not comprehensive studies, and we generally don't recommend these for children. Adults, yes, I think we can do it at home. But for children, you need what is called a level 1 sleep study. So in level 1 sleep study, a child comes to the hospital or a center where there is a proper sleep facility. So what we do is, it's a quiet room. The parent also comes with the child. And what really happens is the child is made comfortable, and then things are explained. And we attach the child to a lot of leads. to measure the oxygen levels, the carbon dioxide levels, the flow rate of breathing, the chest movement, and there's also camera recording how the child is actually sleeping. So once this is set up, let's say by 8 o'clock or 9 o'clock, we let the child sleep. And then through the night, there's a continuous measurement of all of these parameters. So these runs for about 8 to 10 hours, depending on the duration of sleep. And once this is done, the child goes home. The sleep physiologist will analyze the report and will come up with a whole 2 pages or 3 pages of data, which will tell us exactly the quality and the quantity of a child's sleep.
Okay, sir. And coming a bit back to the topic of adenoid hypertrophy, we see a lot of children who have come to us after undergoing adenoidectomy surgery. Even after that, the parents have a common complaint that, sir, my child is still coughing and the child is not able to sleep properly at night due to the cough. The snoring has reduced. But what to do about the cough?
That's a very good question, Somashri, and I think this is a very common problem in our clinic. Now, there is a misconception that you go to an ENT surgeon if you have a cough. Yes, you can see an ENT surgeon if there is snoring, there is a nasal block, or significantly upper airway symptoms. That's fine. But what really happens in real scenarios is that there's a lot of focus on the upper airway. As I was telling you earlier on, that we look at the airway as a unified airway. So whatever is happening in the nose or in the throat is definitely happening in the lungs. So that needs to be identified. Yes, some children will need a straight adenoidectomy or treatment of the adenoids, but a good number of children, the focus is up there, but we're missing the lungs. So any child with a cough will definitely need an evaluation by a pediatric pulmonologist and also by an ENT surgeon, and in combination, decisions need to be made, not in isolation, is what I feel. So it's a combined approach, because you could deal with the nose, but the lung is still there. So I think it's a combined approach, and please see a pediatric pulmonologist if your child has a chronic cough.
In metro cities and even in the peripheries, there are a lot of children that those who have these respiratory problems, their parents are often confused whether to go to a pediatrician or to an adult pulmonologist. So, what should be our message to the parents?
That's a really good question. I think in any city, I think we have a set of very good pediatricians, general pediatricians, who look after the common pediatric problems, either respiratory or any other system. I think they should be the first port of call. But if a child has complex or chronic or respiratory issues which are not being solved at that level, I think families should be directed to see a pediatric pulmonologist. The problem is, previously pediatric pulmonology was a rare specialty, but now we have got good people trained both abroad and in India, and we're having nice departments which are coming up. So I think increasingly I would like to see pediatricians refer children with chronic lung problems to pediatric pulmonologists, either with a physical contact, or we are also available through video consultations for the first consultation. So I think we should use this facility of seeing a pediatric pulmonologist, is what I feel, both in tier 1 cities, tier 2 cities, and even rural areas. And I think the responsibility lies with us to educate families and pediatricians and make our presence a bit more felt, is what I feel.
So, what are the complex diseases that you deal with, sir?
So, along with the simple issues of cough and asthma and those kind of things, we deal with a whole gamut of lung diseases. These start anything with structural problems that you're born with. We deal with conditions of tracheomalacia, inborn errors, where you're born with some issue with your lung but not identified early. That's one thing. These are called structural problems. We deal with a lot of inherited problems which comes through a genetic issue. The two most common conditions that we deal with, one is cystic fibrosis. The second is called primary ciliary dyskinesia. In these two conditions, children start coughing at a very young age. Now, let's say even at 3 months or 6 months, these children have a very bad cough. They're not putting on weight, they're not thriving properly. That's one issue. they also have growth-related problems, especially in conditions like cystic fibrosis. So these two are a big chunk of our chronic lung conditions. People think that these are rare, but increasingly we are seeing a lot in India. So I'm a cystic fibrosis specialist. I see a lot of children with cystic fibrosis. So just be aware that if your child is coughing since a very young age, or the cough is not getting better with standard treatments, or if the growth is getting affected, with a combination of things, I think your child should be referred to a pediatric pulmonologist on an urgent basis.
Okay. So coming to cystic fibrosis, sir, do you think that it is largely an underdiagnosed condition in our country?
Yeah, I think when we were training in India, that's about 20 years ago when we were postgraduates. So we used to hardly see one or two cystic fibrosis cases in India. Now, in the last 3 years, just at Rainbow, we've got about 100 children newly diagnosed, and we get one or two or three every month. So it is a very underdiagnosed condition. One, because people are not aware of it. Second, pediatricians think that it is not common, but it is very common. In fact, some doctors, especially in India, we feel that it may be as common in India as in the West, where it's relatively common. So, being aware of this condition, referring early and investigating and picking it up and treating in good centers. Now, what I want to say is cystic fibrosis is a chronic lung disease. Now, it needs to be managed in specialized centers where there is some experience in managing these kids. You need a pediatrician, you need a pulmonologist, you need a gastroenterologist, a dietitian, a physiologist. So all of these people come together to manage a child with cystic fibrosis. So pick up early, refer early, treat early.
So what is the role of genetic test in cystic fibrosis diagnosis?
So cystic fibrosis, once you suspect in a child, there are two confirmatory tests. One is called a sweat test, where we measure the sweat of a child and the quantity, and also measure the chemicals in the sweat. It's called sweat chloride testing, which is not so easily available, but I think with some good collaboration with institutions like the American CF Society and also CMC Vellore, we are going to get the sweat test equipment more easily available in the country, and definitely in Hyderabad. Now, the second test, which is a diagnostic test, is what is called a whole exome sequencing, where we look at the genetics of cystic fibrosis. So with these two tests, we can diagnose cystic fibrosis.
Okay. And another common query that parents have whenever we prescribe a chest x-ray or a CT scan of the chest is that these tests subject a child to certain amount of radiation. So what are the indications or what are the absolute necessities that we consider when we prescribe a test like CT scan to a child?
So CT scan, I think that's the topic of this question actually. Now, a CT scan is a very comprehensive test which is used widely to look at different parts of the body. So when it comes to the pediatric lungs, I want to look at how the lungs are in the chest. So an X-ray will give us a very rough approximate answer. But if I want to look more closely and more deeply, a CT scan is the test of choice. But this should not be done just like that. I think to do a CT scan in our hospital, in our center, we do a lot of planning. First, we need to decide whether this child actually needs the test or not, because there is a amount of radiation risk involved, as you all know. So that's one thing. Second, what kind of a CT scan? Is it going to be a HRCT or a volumetric CT or a CT with contrast? This is a decision a pediatric pulmonologist will make after discussing with the radiologist. So it's no easy decision. Third, then we need to plan how to do the test. For example, we do it in the older children who can lie down and it's done in 5 minutes. Or sometimes you've got this very young 6-month-old, so we need to have sedation and general anesthetic and all that. So that is also need to be done in a planned way. So for a CT scan, it's a very planned, carefully thought through test, and I think that has to be done. What we see is a very blanket use of CT scans across the community, sometimes done with the right indication, sometimes it's not proper. So any child who needs a CT scan of the chest, I think the doctor should weigh the risks and the benefits very carefully. That's what we do in our practice.
Coming to another test that we frequently see being prescribed everywhere is a blanket allergy panel.
Yes.
So what is your take on this?
So suddenly, that's a very good question. I think suddenly we have a proliferation of allergy testing across the city, which is good and bad. I think it's good in a way that people are getting more attuned to aspects of allergy, and the tests are more easily available. I think the not so good thing about this is that everybody is using this test in a blanket way, and that is completely wrong. Just because the test is there, it doesn't add value to what is happening. So the way I would do an allergy test, or the way we would do it in Rainbow or other good places, is you take a good history, you have a plan. Okay, why is this child having symptoms? Is allergy a part of it or not? Once you make the decision, then your clinical history itself will tell you whether it is because of a food allergen or because of what we call aeroallergen. An aeroallergen is something you breathe in, okay, like dust mite, dust, and those kind of things. So it's only once you make that decision that you need to actually do an allergy test, which should be proper, directed, and sensible. So the misuse of allergy tests is a worry. I feel it should be used, but in a very sensible way.
Sir, in allergy panels, even if we prescribe it, a lot of children they have reports with allergies to multiple things. So, should the child avoid all those things throughout their lives?
No, I think this comes up very often actually. I've got children, as you know, who come to a clinic with a cough, and the doctor has said, don't give milk, eggs, this, that, ice creams, cool drinks, those kind of things. So some of the advice is not very scientific, I think. It's very rare that food itself causes lung problems in children. Sometimes, yes, there's a fact, but there is no role for blanket avoidance of foods or other things. So again, a good history will tell you the diagnosis. And even for in our clinics, we don't do that. What we suggest is take a good history, keep a food diary, make sure that your child is allergic to this. That's one thing which comes from the history. Second, what we do is then we do a very targeted allergy testing. Third, then I think if it's positive, then we go for what is called allergy avoidance. But it's never blanket, it's always targeted.
In many children, we prescribe some chest physiotherapy, some exercises that increase the capacity of the lungs. And also we are using a lot of devices nowadays. Can you throw some light on it, sir?
Yeah, chest physiotherapy is a very important part of what we do in our clinics. A lot of our children, as you know, come with a lot of chronic health problems, cystic fibrosis, bronchiectasis, bronchitis, and so on. And these children, along with medications, inhalers, nebulizations, and antibiotics, they need what is called chest clearance techniques. So there are various devices that we use. We have trained physiotherapists who do manual chest clearance, and then we have a lot of devices that we use in children, including spirometry, a cappella, and so on. So one of the devices, as I was saying, is what is called a cappella. So these are the kind of devices that we use in children with chronic lung problems. These help with lung clearance. So generally these are techniques which you blow into. For example, we teach how to blow this. For example, what we're doing here is this is called the a cappella device, one of the many devices that we use. So this child is sitting up upright and you want to clear his lungs. What we do is we open this, take a deep breath. So when you do this kind of a technique, there's a lot of vibration in the device which actually goes into the lungs, and the phlegm or the mucus starts moving. Okay, so this we do in multiple structured ways so that the mucus actually starts coming up. So this is one of the many devices that we use. This is not the only thing. So this could be done very clearly in consultation with a pulmonologist and help of a chest physiotherapist. So it's a big field actually. So we use a lot of specialists, a lot of devices to help keeps the lungs healthy.
Apart from all these tests and physiotherapists, so another important aspect in children, especially with chronic conditions like cystic fibrosis, primary ciliary dyskinesias, and even in other conditions where there is a prolonged cough, persistent cough, recurrent pneumonias, I have seen that you go for a bronchoscopy. So what are the indications of bronchoscopy in children?
Okay, that's a very good question. Bronchoscopy is a very important part of our day-to-day practice. So, as you know, a bronchoscopy is a very important part of our day-to-day work in a hospital. Now, a bronchoscopy is done by an experienced pediatric pulmonologist. Sometimes you do what's called a flexible bronchoscopy, which is the most common bronchoscopy. Then we also have a rigid bronchoscopy, which we do with the ENT surgeons and surgeons. So now a bronchoscopy is done for three main reasons. One, a diagnostic purpose, when we want to diagnose what's wrong with the child's lungs or the airway. Second, we use what is called a therapeutic bronchoscopy. A therapeutic bronchoscopy is actually used to unblock a lung or a lobe which is collapsed, which is used to actually wash up the lungs when there's a lot of mucus accumulation. Sometimes you stop bleeding. Sometimes you want to diagnose what's happening. You can take biopsies. That's your therapeutic bronchoscopy. Now, the third bronchoscopy, which is what is called an interventional bronchoscopy. So, interventional bronchoscopy is when you use a bronchoscope to intervene. So, the specific reasons is we've got a foreign body in the lungs. So, you go inside, identify the foreign body, and take it out. That's an interventional bronchoscopy. Along with that, the new evolving technology is giving us options to actually use things like cryo, to use things like other devices, for example, what is called kind of fine cone radiation biopsies and things like that. So these are the kind of advanced techniques. Stenting, let's say somebody has got a narrow airway. You can actually open up the airway putting what is called a stent or a balloon dilatation. So this is what is called an interventional bronchoscopy. So bronchoscopy has many indications, and I think these are the three broad categories.
Okay, and coming to this bronchoscopy, sir, parents may have a doubt that is this procedure going to cause pain to the child? Any bleeding will be there, and what is the approximate duration of the total procedure? Is it a major surgery or something that can be done by daycare also?
Yeah, so that's a very good question. I think this is a question a lot of families have. Look, a bronchoscopy, for all said and done, it's an invasive procedure, isn't it? But if it's done in a good center by experienced people and by pediatric pulmonologists with a clear idea of what he's doing, then I think it's a very safe procedure. As you know, you've been here for a good amount of time. We do about 300 bronchoscopies a year. We hardly have any major side effects or issues. So done properly, I think it's a very safe procedure. It's normally done in children under sedation, deep sedation or mild general anesthesia. There's a lot of pain control. A child will never feel a bronchoscopy while doing the procedure or even after the procedure. So kids wake up, they're hungry, they want to eat. That's all they want to do. So it's a very safe procedure. Now, as you know, we've done bronchoscopies from a very wide age group. Children with hardly 1 month old to 16, 17-year-old children. So it's a very safe procedure, but done properly. Now, there is also a tendency to do bronchoscopies in many other centers by adult pulmonologists and other people, which may be okay in certain situations, but generally, if a child has got chronic health issues, a planned bronchoscopy where a lot of specialists are involved. For example, sometimes when we're doing bronchoscopies, we have a pediatric pulmonologist, we have an ENT specialist, we have the pediatric surgeons, all in the same room, just ready to act when required. Because I think sometimes you need this multidisciplinary input. So for complex bronchoscopies, best done in a center where we've got multiple specialists available in a planned way. To cut your the thing short, what I want to say is a pediatric bronchoscopy is a very common procedure. It is very safe, it's very painless, and done properly, it gives you very good information.
And there are some children with cardiac issues who are often referred to a pediatric pulmonologist. So, what are those conditions, sir?
Yeah, so I think what we see is we work very closely with the cardiology teams here. Now, see, the lungs and the heart are in the same chamber, isn't it? So it's the chest. So a lot of lung problems can affect the heart, a lot of heart problems can affect the lung, and there's a lot of interplay between the two specialities. Okay, one of the common things that we see is called pulmonary hypertension, where the pressures in the lungs go up because of lung issues or the heart issues. So sometimes it needs a lot of teasing out to understand why this is happening. As you know, we see a lot of airway problems. Kids with complex heart diseases can have narrowing of the trachea and the bronchi. So this needs a lot of evaluation with the pediatric pulmonologist. Now, there are a lot of children with heart diseases who definitely have lung problems. For example, a child with primary ciliary dyskinesia. So it's a very close relationship between the two specialities. So I think very close team working is important, so that sometimes there's a lot of a cross cover between these specialities, isn't it? We see a lot of that. Yeah. It was a great interview, Sumishri, and I think one message I'd like to give to the parents is that we get one pair of lungs, just like one heart, isn't it? Sometimes we neglect the lungs, but these are very hard to replace. I think that's something we would say. Whatever happens in childhood, now there is a very clear evidence that there is what's called early onset of lung disease. So whatever starts in childhood needs to be addressed very quickly, or it can go on to cause more problems in adulthood. So what we follow is a theme called lungs for life. So look after your lungs from a young age, and they will serve you when you're older. I think that's my message to the families.
Thank you so much, sir, for your valuable inputs. And of course, we had a great deal of discussion among the common problems in the pediatric respiratory field. I want to say to the parents that if you have any questions about your child's respiratory problems, sleep problems, allergies, or any complex airway disease that your child is having, feel free to contact with us at Rainbow Children's Hospital, Hyderabad, and we'll be very happy to help you. You can also post your questions in the comment box underneath. Thank you.